Welcome to this executive training module titled Decoding 42 CFR Part 460 and CMS Compliance. This session is specifically designed for medical executives transitioning from the productivity-driven landscape of fee-for-service medicine into the capitated value-based environment of the Program of All-Inclusive Care for the Elderly, or PACE. The shift from a system that rewards the volume of interventions to one that rewards the quality of outcomes requires not just a clinical pivot, but a deep mastery of the regulatory architecture that governs the PACE model. The core learning objectives for this 60-minute lecture are twofold. First, we will provide a comprehensive interpretation of the statutory requirements governing PACE as codified in 42 CFR Part 460. Second, we will analyze the specific protocols of the three-way program agreement and the critical regulations surrounding conflicts of interest. You should have your 42 CFR Part 460 reference guide and CMS PACE manual. Chapter 2 ready for consultation, as these documents serve as the primary evidence base for the principles discussed today. Why is this high stakes for a medical director? In the PACE world, the medical director is not simply a senior clinician. The medical director is a structural requirement of the program's legal existence. Noncompliance with the administrative mandates, ranging from personnel notification timelines to conflict of interest disclosures, can lead to severe administrative sanctions. These include the suspension of enrollment, civil monetary penalties exceeding $100,000, or even the termination of the program agreement. This lecture translates dense regulatory text into actionable leadership principles. Yamarisar, Module 1, the statutory foundations and the three-way agreement. To understand PACE, one must understand its origin as a unique partnership. As noted in the PACE Manual Chapter 1, PACE is a permanent entity within the Medicare program and a state option under Medicaid. This dual status is formalized through a three-way program agreement between the PACE organization, the Centers for Medicare and Medicaid Services, or CMS, and the State Administering Agency, or SAA. Under 42 CFR Section 460.30, a PACE organization cannot exist in a vacuum. It must have a signed agreement from all three For a medical director, the primary implication of this agreement is the strict definition of the service area. Unlike a private practice that can see any patient who walks through the door, a PACE organization is legally restricted to serving participants within a specific geographic area defined by zip codes, counties, or street boundaries. What happens when the organization wants to grow? Any change in the designated service area, or the sites where services are performed, must be approved by both CMS and the SAA before the change takes effect. This is not a mere suggestion, it is a contractual obligation. If a medical director begins treating participants in a new zip code before the program agreement is formally amended, the organization risks being found in violation of its contract, which can lead to a denial of payment for those participants. The program agreement also incorporates Appendix M, which outlines the Medicare and Medicaid payment amounts. Because PACE is a capitated model, the organization receives a fixed per member per month payment. This creates an inverted economic reality. The medical director must view every clinical decision through the lens of this capitated budget. In a fee-for-service world, a hospital admission is revenue. In PACE, a hospital admission is a cost that must be managed through superior primary care and interdisciplinary intervention. Let's summarize the executive implications of this agreement. The tripartite signatories require constant alignment between the organization, CMS, and the state. The service area definition restricts your enrollment to approved geographic boundaries. Most importantly, the capitated payment structure shifts the financial risk entirely to your organization, and your agreement is automatically extended each contract year unless specifically terminated. Murarasakwer Module 2, Organizational Structure and the 14-Day Personnel Rule. Moving into the administrative requirements of Subpart E, 42 CFR Section 460.60 identifies the key personnel that a PACE organization must employ or contract. These are the program director and the medical director. The medical director is specifically charged with the delivery of participant care, clinical outcomes, and the implementation and oversight of the quality improvement program. There's a specific regulatory mandate that often catches new executives off guard. According to 42 CFR Section 460.60, subsection C, a PACE organization planning a change in its organizational structure must notify CMS and the SAA in writing at least 14 days before the change takes effect. Why does this matter? Because the medical director and the program director are considered key personnel. A change in these roles constitutes a change in the organizational structure. If a medical director resigns and a successor is appointed without providing that 14-day advance notice, the organization is in immediate non-compliance. Imagine a scenario where a PACE organization is acquired by a larger health system. The new parent company decides to replace the medical director with one of its own regional executives. If the regional executive starts the job on Monday, but the notice to CMS was only sent on the previous Friday, the organization has violated the 14-day rule. During a CMS audit, this gap in notification is an easy finding for surveyors. It suggests a lack of administrative control and can lead to a corrective action required status. The medical director must also ensure that the organizational chart is current. Under Section 460.60, this chart must show the relationships between the PACE organization and any parent, affiliate, or subsidiary entities. This transparency is intended to prevent hidden corporate influences from overriding the clinical autonomy of the PACE program. Module 3, Governance, Participant Voice, and Program Integrity. The governing body, often a board of directors, holds the full legal authority for the PACE organization. However, unlike a standard corporate board, a PACE board must integrate the participant voice. 42 CFR Section 460.62 mandates that there must be a participant representative on the governing body. This representative serves as a liaison from the Participant Advisory Committee, another mandatory body where the majority of members must be participants or their representatives. For a medical director, the Participant Advisory Committee is a vital early warning system. If participants are unhappy with the quality of meals at the center or the wait times for transportation, those issues will surface in the committee minutes, which must be provided to the governing body. Program integrity also involves strict rules on who can be employed. Under Section 460(68), a PACE organization is prohibited from hiring anyone excluded from Medicare or Medicaid, or anyone convicted of crimes related to health programs or the abuse of individuals. The medical director must oversee the clinical credentialing process to ensure that every physician, nurse, and therapist has a clean background check and is practicing within their state-defined scope of authority. To ensure compliance and governance, remember that a participant, caregiver, or advisory member must have a seat on the board. Criminal background checks are required for all staff with direct participant contact, and licensure must be verified to ensure staff are legally authorized to practice in the state. Finally, always remember the 14-day notice rule for changes in key personnel. Module 4, Conflict of Interest and Fiscal Transparency. We now come to one of the most critical sections, conflict of interest. 42 CFR Section 460.68, subsection B, requires the organization to identify any member of the governing body or any immediate family member who has a direct or indirect interest in any contract supplying services or materials to the PACE organization. The term indirect interest is broad. It includes holdings in the name of a spouse, a dependent child, or even a relative who resides with the board member. If a board member's spouse owns 10% of the pharmacy that provides medications to the PACE participants, that is an indirect conflict of interest. The regulation requires a two-step process for handling such conflicts. First, full disclosure. The nature of the conflict must be disclosed to the board and documented in the minutes. Second, recusal. The board member must recuse themselves from discussing, negotiating, or voting on any issue or contract related to that interest. Consider this scenario. A PACE organization is looking to renew its contract with a local ambulance company. One of the board members is the retired CEO of that ambulance company and still holds significant stock. During the board meeting where the contract is discussed, that board member must leave the room. If they remain in the room, even if they do not vote, the organization has failed to follow the recusal requirement. Why is CMS so strict here? Because PACE is a capitated model. Every dollar spent on a contractor is a dollar that isn't available for direct participant care. CMS wants to ensure that contracts are awarded based on value and quality, not because of board-level favoritism. The medical director must champion this transparency to protect the organization from administrative sanctions and ensure that fiscal operations are focused on participant health. Module 5, the interdisciplinary team as the clinical decision engine. In the fee-for-service world, the physician is often the sole authorizing agent. In PACE, that authority is shifted to the interdisciplinary team, or IDT. Under 42 CFR Section 460.102, the IDT is responsible for the assessment, development, and implementation of the plan of care for every participant. The IDT must be composed of at least 11 roles. This includes the primary care provider who manages medical situations and oversees specialists, the registered nurse responsible for clinical assessment, the master's level social worker for psychosocial support, and physical and occupational therapists for functional assessments. The team also includes the recreational therapist, the dietitian, the PACE center manager, the home care coordinator, a personal care attendant, and a driver. The medical director oversees this team to ensure that clinical decisions are made by consensus, not by individual command. This is a profound shift for a physician. If the physical therapist believes a participant needs a specific piece of equipment to stay safe at home, the IDT must discuss and authorize it. The medical director cannot simply overrule the team for fiscal reasons. One of the most important regulatory tasks for the IDT is the initial comprehensive assessment. Under Section 461.104, every mandatory member of the team must evaluate the participant in person. Within 30 days of enrollment, these assessments must be consolidated into a single plan of care through team discussion and consensus. A failure in this process, such as a driver not being included in the care plan discussion or a social worker failing to complete an in-person assessment, is a direct violation of PACE regulations. During a CMS audit, surveyors will look for service determination requests and ensure that if the IDT denied a service, the reasoning was documented and the participant was informed of their right to appeal. Module 6, Quality Improvement and the QAPI Program. Subpart H of the regulations details the Quality Assessment and Performance Improvement, or QAPI, program. The medical director is legally responsible for the implementation and oversight of this program. According to 42 CFR Section 460.136, a PACE organization must use outcome measures to identify areas of good or problematic performance. These measures must include physiological well being, functional status, and quality of life. A realistic scenario for a medical director involves fall prevention. If the data shows an increase in falls at the center, the QAPI program must trigger an investigation. The medical director would lead the team in analyzing whether the falls are linked to medication changes, physical environment issues, or a lack of supervision. Any identified problem that threatens the health and safety of a participant must be corrected immediately. The medical director must also ensure that all staff and contractors are involved in the quality improvement activities. This means that if a contracted hospital has high rates of readmission for PACE participants, the medical director must engage with that contractor to develop a corrective action plan. Module 7, CMS Monitoring and Audit Preparedness. PACE organizations are subject to intense monitoring, especially during their first 3 years, known as the trial period. During this time, CMS and the state conduct comprehensive annual reviews to ensure substantial compliance with all requirements of the Act. The CMS audit protocol has introduced requirements such as standardized impact analysis templates and case file cover sheets to improve the transparency of medical records. Audit preparedness happens in phases. In the data submission phase, the medical director must ensure the accuracy of clinical encounters and HCC coding. During fieldwork, you must be prepared to defend clinical consensus and service denials. In the reporting phase, you will analyze any identified deficiencies, and in the final phase, you will lead the clinical implementation of any required corrective action plans. A medical director must be audit ready at all times. This means ensuring that the IDT documentation loop is closed. If a participant was hospitalized, did the IDT review the discharge recommendations within 48 hours? If a participant requested a specialist visit, was that request authorized or denied within the required time frame? And our Heart Module 8, Sanctions and the Consequences of Noncompliance. Finally, we must discuss the teeth of the regulations. Subpart D allows CMS to impose sanctions for violations such as failing to provide medically necessary services, discriminating in enrollment, or misrepresenting information. Civil monetary penalties can be catastrophic. For example, a violation regarding enrollment discrimination carries a base penalty of $100,000 plus $15,000 for each individual not enrolled as a result. These amounts are adjusted annually for inflation, making the current stakes even higher. If CMS finds that an organization has failed to correct a violation, they can suspend all new enrollments or even suspend Medicare payments. For a capitated program, a suspension of payment is an existential threat. The medical director's role in compliance is therefore a role in organizational survival. There are conclusion and action items. In summary, the transition from fee-for-service to PACE leadership is a transition from clinical practitioner to clinical executive. Mastery of 42 CFR Part 460 is not an administrative burden. It is the fundamental tool for ensuring that the interdisciplinary team operates with integrity, that the organization remains fiscally sound, and that the participants receive the high-quality, all-inclusive care they are promised. Before we conclude, here are 3 immediate actionable steps for every medical director. First, review your 14-day notification protocols. Ensure that your human resources and compliance departments are aligned to notify CMS and the state of any key personnel changes before they happen. Second, audit your board minutes. Check for the documented disclosure and recusal of any direct or indirect conflicts of interest among your governing body members. Third, evaluate your interdisciplinary team's documentation loop. Conduct a mock audit of 5 random charts to ensure that initial assessments were completed in person by all mandatory roles and that the unified plan of care was completed within 30 days. Thank you for your leadership and your commitment to the PACE model. By decoding these regulations, you are protecting your participants and your organization. This concludes the lecture on Decoding 42 CFR Part 460 and CMS compliance.